Welcome to This Just In, the show bringing you the latest advancements in healthcare, strategy, innovation, and public policy. And now, for the fastest voice in healthcare, here's your host, Justin Barnes.
Thank you for tuning in. Welcome to This Just In. I'm your host, Justin Barnes. In these episodes, I'll bring you the latest advancements in healthcare, strategy, innovation, and leadership. As always, we're broadcasting from the This Just In studios on the Business Radio X network, the Healthcare Now radio network, and the Health Podcast Network. I could not be more excited for this show, my 352nd episode. I have two of my show's most frequent and favorite guests back to launch their latest masterpiece, Transform. Welcome back, Dr. John Halamka and Mr. Paul Cerrato. How are you, gentlemen?
Good, thank you.
Doing great.
Awesome. Again, I appreciate you both joining me for this special video presentation and production to discuss Transform. Before we dive in, I assume you both are having a great start to your summer. John, you having fun yet so far?
Well, the great thing about living in New England is you get seasonal expectations. And when it's hot, you want it cold. When it's cold, you want it hot. You always want what it's not.
You got it. You got it. Well, I grew up in Massachusetts, as you know, as well, and it's a very, very special place. Certainly this time of year. Well, you got fall and spring are beautiful too, but the summers are a lot of fun. You get some good diversity there. Love it. And Paul, you're in upstate New York?
Yeah, well, I'm about an hour north of New York City, and we just got back from a summer house in the Catskills where we had a bit of a family jam session. We put all the musicians together to have a good time.
Awesome. Fantastic. Great. Well, I know the last couple of weeks, we've been discussing the book. I'm grateful for this opportunity again to dive back in kind of on the video production of this. So before we dive into some of the questions and the follow-up, what was the genesis of this particular book? What made you write it now? And some of the, the main reasons behind it?
Paul, why don't you start on that one, and then I'll offer some commentary, literally from conversations I've had this morning.
Perfect.
So I think it can be summed up in one word: ChatGPT.
Yeah.
The whole world is suddenly taking notice and using this tool, and the fact that it can be easily abused and used in a beneficial way was one of the things that got us started going in this direction to write the new book.
Excellent.
So this morning I've had conversations with an ambassador from Norway and government leaders in the UK. And they said, our societies need to transform because we're solving critical problems in healthcare, supply-demand mismatch, quality, availability, and we're just not quite certain how we should move forward. Do you have a roadmap? And there you go. You hand them the book and say, here's your roadmap.
Love it. Love it. So in the book, you both emphasize that AI in healthcare isn't magic, it's math. Can you expand on why it's critical that consumers and professionals alike understand this distinction as AI becomes more pervasive in the market? You want to start here, John?
Well, this is a philosophical question.
Mm-hmm.
So I'll ask you, Justin, you went to school for a dozen or more years.
Yes.
What was it that you learned in the dozen or more years? The answer was patterns. That is, you read material, you interacted with colleagues. It was all about, wow, I saw what yields success and what doesn't, what seems to be factual and not. Well, it isn't that AI is reasoning, but it's very good at taking the patterns of millions of people experiences and then giving you a sense of what the right forward path could be. And that's where, if you understand it as probability, synthesizing the experience of others, you understand why it's useful.
That's excellent. So, Paul, you want to chime in there?
So math versus magic. I think if the public sees these tools as magical, they're more inclined to label them evil or good. Magic usually comes to mind words like black magic or heaven sent. So if you remove all that subjectivity out of it, you're more likely for folks to see it as it really is.
Yeah, excellent point. And John, you make me think about why I went to school so long, and what also I learned, what's really important. I think everybody, no matter how your brain functions, in school you learn how to learn, which sets you up for learning long term. So that, for me, that was really school. I certainly learned some specialties and specifics, but learning how to learn and opening your brain, training your brain how to learn, I think is critically important also in education. Actually, before you joined, Paul and I were just talking about that kind of topic. So, yeah. So, from liquid biopsies to personalized genomics and pharmacogenetics in genomics, what are some of the most exciting clinical advancements made possible by the Mayo Clinic platform and your AI partnerships?
In my mind, the most exciting thing is the algorithms that are helping improve colonoscopies. There are now, and we mentioned this, we show pictures in the book of how algorithms are now helping to detect small polyps that were missed previously. So it's saving lives.
What's most exciting to me is the capacity of these systems, predictive and generative, to digest massive amounts of material that exceed the human capacity to do so. So remember, I was the second human sequenced in the Personal Genome Project. I have 3 billion base pairs unique to me. Is a clinician going to go read my 3 billion base pairs? Pretty hard. For an AI to read 3 billion base pairs? Milliseconds. So it's this capacity of taking this overwhelming amount of data we are now generating and turning it into wisdom.
No, that's fantastic. Um, yeah, you make me think about just some of the, the advancements not only on the healthcare side, but also in specifically for the care providers, but also this is really helping us as consumers. And that's really why, I want to kind of talk about this. This is a great topic. And this book was written, we'll touch on that later on in another question, that this is a consumer-based book. But us as healthcare consumers, we really need to start looking at how AI can benefit us. So I think, Paul, this goes to what you were saying. Again, it's going to help clinicians make decisions, John, as you touched on, but also patients. There's so much opportunity as patients in this regard to see how AI can assist us in our own world. And that's, again, why I really want to talk about this book, and I thoroughly enjoyed it. So I know you both believe that as well. In the book, we touch on the risks of AI inputs and the importance of validation. And John, you've been talking about this for many years. How did Mayo's Validate program help ensure trust in AI-powered healthcare?
Well, there's two aspects of validation. Is this algorithm or AI system mathematically sound? And then what are the risks and the clinical implications of using it? So math, wow, I'm going to predict that Justin is going to have a tan this summer. Well, how do we assess that? Well, what latitude and longitude does Justin live in? How many hours a day is Justin outside? Does Justin use sunscreen?
Yes.
You could say, oh, I've actually mathematically shown that more sun exposure leads to more tanning.
Yeah.
Okay, that's math. But now, what about the safety of using such an algorithm? What are the clinical implications? And I, of course, I'm making this up, but if the algorithm suggests that everyone goes and spends more time in the sun, that may not be the greatest thing.
That's right.
And so Mayo is doing both the math and the clinical correlation.
Yep. Love it. Paul, your thoughts there?
Now it's kind of hard to follow that up, but he said it all.
Yeah. And I do wear sunscreen and I do get early morning sun. I do spend a lot of time outside, but usually before 9 a.m. So get my vitamin D. Yes. And I'm the guy that you'll find on the beach if I go to the beach under an umbrella with a lot of sunscreen. So in the book, the idea of deploy as a sidecar to EHRs is a fascinating one. How can solutions like this help overcome the friction that exists in health in today's clinical workflows? John, you've spent a lot of time on that as well.
So I have been in 5 countries since we talked last.
Yeah.
And do you know that every one of those countries are saying the same thing? Our innovators are actually producing these systems, but they're not getting used because it's too hard to insert them into workflow. I was talking to my EHR vendor, my PACS vendor, my CIO. Oh, they said, oh, too much effort, too much time, too much cost. And so the question is, if you can reduce the time from innovation to dissemination to hours and 0 cost and low effort, then you'll get adoption.
It's excellent.
And that's exactly what Deploy does. It's a state-of-the-art infrastructure, and we bring into the recipe skilled technical expertise so that hospitals can take the algorithms that they have and put them into programs like Epic, which is the major EHR system.
Yeah, I mean, You touched this a little bit, but I mean, even technologies to give people an idea of some, even the next level down is like ambient listening as a type of functionality, AI-driven functionality that's out there. You want to take a second on ambient listening? Your thoughts there, John, or even in Paul?
John's the expert there.
Yeah.
Right. Well, so ask this question. If you're a doctor, you're a nurse, you're a social worker, how much time do you spend with patients versus keyboards?
Hmm.
And I could argue the EHR revolution was wonderful in that it captured records for data analytics, for understanding of quality and safety, but we lost the hearts and the minds of our clinicians along the journey.
Yeah.
So the notion of ambient listening, that is, a computer can listen to the doctor or nurse and patient talking and write the record, is starting to give something back to the clinicians. So we get the benefits without the administrative burden.
Yeah. Anything you want to add on to that, Paul?
No, that's good. You said it all.
Yeah, I'm very excited about this innovation. Our providers need it, but also you brought up we have a lot of clinician burnout for a lot of obvious reasons, and one of the big ones is the EHR and the technology that we've kind of pushed in that direction. But also the patients are going to love this type of innovation, and there's lots of cool stuff coming out. But this type, specifically ambient listening and innovations like this, will give that physician-patient interaction much more back to that quality that you're talking about, John, that we had 15, 20, 30, 40 years ago. So,
And there's some other interesting characteristics. This is actually a real story.
yeah.
A doctor putting on the stethoscope while the patient was talking, and then the doctor did the exam, and after the exam said, well, here's what I've concluded. The patient said, but wait, I already told you that wasn't going to be the source of the problem. So wait, I didn't hear it. And then, of course, they went back to the ambient listening, and the ambient listening had perfectly recorded what the patient said while the doctor was putting the stethoscope on.
Yeah. I actually remember I remember that story previously. That's fantastic. And that's, just a tip of the iceberg of the opportunity for sure. We touched on this a couple of minutes ago. You made a point of writing this book for the consumer audience. Why is it an important step outside of the traditional medical and tech professional audiences for Transform? I mean, why did you do that specifically?
Yeah, there are so many bizarre stories coming out now about how ChatGPT and Claude and all these other large language models are freaking people out. I mean, they're tricking people. In some cases, people are getting phone calls from, quote, their grandson who's being kidnapped, and please send, X number of dollars. And this is largely the result of ChatGPT being so effective in mimicking the human voice. So we felt it was really necessary to help folks understand the benefits and the risks of these new tools.
And
Yeah.
Justin, I may have told you this previously, but in 1972, I was having a discussion with my father, and I said, Dad, the difference between analog and digital is just the question of how finely we digitize the object from the real world. There'll be a time in the future when the digitization is so fine, you won't be able to tell the difference.
Right.
And my father said, oh, that'll never happen.
Yeah.
Well, here we are,
Well,
2025. It's
yeah.
happened.
It's happening.
Absolutely. No, that's very true. So previously we just actually in the last discussion we discussed the Mayo Clinic Platform. You mentioned having 56 million patient records and multiple billions of data points. How do you navigate the privacy, ethical, and psychological barriers when building global data collaborations?
That's all
Buy
about,
the book.
Good point.
Paul.
it's all about data behind glass. This is a whole system we have. It's a federated system that allows third-party developers to work with the data to create algorithms to conduct analysis, but the data itself can never leave the secure container controlled by Mayo.
Yeah.
Right. As Paula said, we analyzed the regulatory frameworks, but also the cultural expectations of countries around the world. We actually used 12 different criteria of looking at what infrastructure they have, what is their spend on healthcare, what is their likelihood to adopt innovation. And what we found was some common characteristics, and that led us to develop a model that works in most places in the globe, de-identifying the data, keeping it stored in a secure way, and having appropriate governance over its use.
Yeah. What are some of I assume US is leading a lot of the charge, if not all of it there. That's an assumption. Um, what are some of the other countries that you think really are taking this without, calling anybody out specifically up and down, but what are some of the countries that are really advancing here alongside us, America?
Well, you have to be careful about being too US centric in your view of this.
Yeah.
So suppose you're in Denmark and at age 44, you develop a cancer. Well, you can just go back and see what medications you had at age 4 and figure out if there's a relationship between the care you received as a child and the disease you developed as an adult. Try doing that in the US. Well, it's
Right.
hard.
Yeah.
And so you have societies like Singapore,
Hmm.
Northern Europe, that have really done a good job of bringing together life experiences, and that includes medical care, but social care, a whole variety. I mean, if you look at Estonia, of the things you do in life.
Hmm.
So, how about this? Many other countries are doing a better job in organizing the data and making it available to you and others who work for your benefit.
It's excellent. 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 Anything you want to share with there, Paul?
No,
Additional?
that says it all.
Yeah, and I totally agree with you, John. I think back, there's a group of us from, at the time it was MGMA in 2011. Like 15 of us went to Cuba to study their healthcare system, and they didn't have the money to adopt technology as much as they're just extremely inventive in how they created community-based care. So really, it was almost like an FQHC structure in a way, but where the physician would have about 1,000 patients in the community. They're the lowest, fetal death rate in the world, Cuba, because of the way they take their all women, no matter what their socioeconomic status, can go into a woman's home and basically being taken care of for almost the full 9 months of their pregnancy if they wanted to. So great, sleep, food, nutrition, care, everything. So that's why their babies were born, very healthy in many ways. But then also just look at the way the communities, the doctors and care structure cared for that community of 1,000 or 1,200 people. So again, they're probably much better than us today, just because of how disparate we've gotten in our society, in our community. So learned a lot from that. So I totally agree with you. It doesn't have to be U.S. centric in that regard, for sure. Um, so now getting back on the technology side, generative AI and large language models are at the heart of today's healthcare revolution. What are the biggest misconceptions about their use, and how are you and Mayo working to correct them? You want to take that, John, to start off with? I mean, sorry, Paul.
Well, Paul just wrote a lovely
Yeah,
piece on exactly that topic. So go
yeah.
for it.
Yeah. So I think one of the biggest misconceptions is people believe that ChatGPT and these other large language models can reason. And in fact, they don't reason in this human sense of the word, that is, with probability and real world truth and logic. What they're doing is basically stringing together a series of words in a way that seems logical. So people jump to the conclusion that they're reasoning in the human sense of the word, and they're just not.
Mhm.
Well, and one of the fun things that we wrote about yesterday was, wow, I heard about a study that was done where a generative AI tried to blackmail its author or tried to refuse a shutdown command. So when you read stuff like that,
Right.
it seems to imply that there, as you just heard from Paul, that there's reasoning or that there's volitional action. Well, we chatted with some experts on this, and they say, well, what if I gave the ChatGPT model all the dramatic literature that had been published in American fiction that included blackmail and threats and retribution? And then when I interacted with it, it exhibited blackmail, threats, and retribution. It's not doing it volitionally. It's
Right.
simply a reflection
Excellent.
of the language that was used to train it.
Very, very good point. Oh,
So one of the solutions is to use a large language model that does not rely on the entire internet with all its garbage and good stuff. There are uh, programs like Open Evidence, for instance, which relies primarily on reliable sources like PubMed and the New England Journal of Medicine and JAMA. So if that's the data set, you're much more likely to get an accurate, reliable response to your query.
yeah, and based on, I mean, I took your advice. We've discussed that before, and so when one of my companies now, my main organization, my the small language model that I created is for each of my customers has their own small language model. I only I curate the content that goes in there. Based back to your point, Paul, is having has to be a trusted source and from fact-based information that I've already curated myself to know to be factual. So when I do pull, the output, I know is either evidence-based or fact-based or what I'm looking for specifically, not opinions or other stuff outside from the internet. So
Yeah, that makes sense.
yeah.
And so you raise this really interesting question because I asked Eric Schmidt, who serves on the board of Mayo Clinic and, of course, used to run Google and Alphabet.
Yep.
Will these large foundation models eclipse the small niche models developed for a specific purpose? And his answer was no,
Right.
because these small niche models are much more likely to be consistent and believable and helpful.
Yeah. Thank you for that, because so far that's my my findings as well. That's great. Good. So how does social determinants of health fit into the future of precision medicine and algorithmic healthcare? Can AI help close the gap, or will it make it worse if we're not careful?
So I guess you got to start with asking, well, what are the social determinants of health that need to be measured? Things like what's your neighborhood, uh, whether or not you have access to healthy food or you live in a food desert. Um, how educated are you or the patients that you're working with? How lonely are the patients? How isolated are those? So you have to look at all of those social determinants and then measure them in some useful way so that they can be folded back into the diagnostic and the treatment decision. Mayo Clinic has a system called Houses, which I'm sure John can tell us a lot about.
With the idea that for every patient, you'll look at the latitude and longitude of where they live. And since we've mapped every grocery store, primary care office, crime statistics, educational opportunities, unemployment, for every latitude and longitude, we can understand some 40 different, what we'll call socioeconomic stressors around the individual based on where they live.
Wow. Yeah, I love it. It's awesome. You've worked for, certainly you, John, have worked for years on Coalition for Health AI, CHI. What's the long-term vision here, and how can the average healthcare system or startup contribute meaningfully?
So here's a vision for you. We know that in the United States, but also globally, there will be innovators creating brilliant solutions. Problem is, we won't know about them. We won't know if they're good or bad or useful for the person in front of us now. So recently, CHI announced a global registry where any innovator can post what we call the data card and the model card, which is what data did I use to create the model and how does that model perform? It may be very, very good for people who wear lots of sunscreen and only go out before 9 in the morning. And so the challenge, of course, is if you have this global registry, if you could connect the electronic health record, the PACS system, or the app you're using on your phone to that registry, and the registry would then say, this is likely to work for you and give you useful advice, we'll get dissemination of innovation and quality and safety much more rapidly than searching the internet for an algorithm of unknown quality.
Well said. Excellent. Very, very true. Anything you want to add on there, Paul?
No, that sums it up nicely.
Well, cool. Coming to my last question. I always love this piece. You guys both crush it. Looking ahead, what gives you the most optimism about where we're headed in digital health and how AI will shape the doctor-patient relationship in the next, I said 3 to 5 years, but even next 2 to 3 years. You want to start off, Paul?
I still think it's generative AI, despite all the problems it has right now. Eventually, in the hands of responsible, ethically motivated developers and clinicians, we're going to see diagnostic and treatment assistants that are indispensable. And I dare say that it's going to get to the point where a clinician who does not use these type of tools will be verging on malpractice.
Yeah. Or
Not that they should replace him or her, but ignoring them would be a mistake eventually.
Well said. Excellent.
And why am I so optimistic? I've been at this for 50 years. We are now at this time in history where the data is good enough. The technology to turn that data into wisdom is available, inexpensive, and high quality. And there's a societal urgency to change because we're seeing aging societies in most of the world and not enough caregivers. So we are poised as we go from 2025 to 2026 to a great leap in the application of these technologies for the betterment of global health.
That's fantastic. Great answers, gentlemen. Always a true pleasure. We're at time. I'm grateful for both of you for coming back on and launching a new book with the show, Transform. It's always great having you both on air, and I certainly look forward to next time. Thank you, gentlemen.
Thank you.
Thank you.
And a big thank you to all my listeners and supporters who voted us 2024 Podcast of the Year. We are so grateful. Please tune in as this show broadcasts weekdays at 2:30 p.m. Eastern, 11:30 a.m. Pacific. As always, you can find me on LinkedIn at Justin T. Barnes or track me on Twitter at HIT Advisor. And you use the hashtag ThisJustinRadios to respond to your comments from the show. If you miss any of this episode or want to hear more, all my shows are posted on YouTube, Spotify, Apple iTunes, Amazon Music, Megaphone, SoundCloud, iHeartRadio, and TuneIn. Thanks again, everybody, for tuning, and have a great rest of your day.